Hi everybody, so my name is Lorna May L Mesa and I'm a third-year nursing student. This is the second video of a 4-part series where I talk about different topics. So keep on watching. Thank you. For this topic, we will be talking about disseminated intravascular coagulation. This is basically a summary of what we need to know. First, what is disseminated intravascular coagulation? It is also known as consumption coagulopathy. Why? Because excessive intravascular coagulation leads to consumption of platelets and non-enzymatic coagulation factors. Therefore, clotting factors are basically consumed. It is a rare but serious condition that causes abnormal blood clotting throughout the body's blood vessels. Take note, abnormal blood clotting throughout the body's blood vessels. Next, what are its risk factors? First is infection. Sepsis, a body-wide response to infection that causes inflammation, is the most common risk factor for DIC. The infection may be caused by parasites, bacteria, fungi, or viruses. Next is injury. Major damage to organs or tissues can raise your risk of DIC. Examples of diseases that causes major damage to organs or tissues are cirrhosis, pancreatitis, severe trauma or injury, burns, or major surgery. Next risk factor is lifestyle habit. The use of illegal drugs like cocaine and ecstasy may increase the risk of DIC. Next are other medical conditions like blood vessel abnormalities, cancer, heat stroke, pregnancy complications, and severe immune reactions. What are the causative factors of DIC? First is inflammation. This is in response to infection, injury, or an illness. Next is severe tissue damage, such as from burns or trauma. Next are clotting factors caused by some cancers or pregnancy complications. So pregnancy complications that produce clotting factors include number 1, placental abruption. This is in which the placenta separates from the uterus. Number 2, amniotic fluid embolism. This is in which amniotic fluid that surrounds the unborn baby enters the mother's bloodstream. Next, what are the signs and symptoms of disseminated intravascular coagulation? So there are a lot. I will just be enumerating each one of them. First is bruising. This may appear easily and often in various areas as small dots or larger patches. Next is bleeding at the site of wounds. This is from surgical cuts or from placement of needles. Next is bleeding from the nose, gums, or mouth, including when a patient brushes their teeth. Next is blood in the stools or tarry stools. This is from bleeding in the intestines or stomach. Stools may appear dark, red, or like tar. Next is blood in the urine, and then chest pain, trouble breathing, and shortness of breath. There is also confusion, speech changes or trouble speaking, dizziness or seizures. Headaches can also occur, low blood pressure, pain, redness, warmth, and swelling in the lower leg. There are also unusually heavy periods for the women. So how do we detect disseminated intravascular coagulation through diagnostic procedures? There are various ways to detect disseminated intravascular coagulation. First is a medical history. Next is physical examination. Next is blood clotting tests like prothrombin time and partial thromboplastin time. This was discussed in the previous video. Prothrombin time is the test that evaluates the ability of the blood to clot. Partial thromboplastin time, on the other hand, determines if the blood thinning therapy is effective. Next is complete blood count. Fifth is comprehensive metabolic panel. There is also D-dimer tests that you can do, peripheral blood smear, and serum fibrinogen test. So the physician may use a scoring system to diagnose DIC. The score will be based on the platelet count, the prothrombin time, the D-dimer test, and the fibrinogen levels. Okay, now let us proceed into the disease process or the pathogenesis of the disseminated intravascular coagulation. As you can see, there are 3 colored boxes in this diagram. There is a legend on the left side of the screen, as can be seen, and then I will proceed on with the disease process. So sepsis can diffuse activation of inflammatory cascade. Cancer, on the other hand, causes the presence of cancer procoagulant. Trauma damages endothelial cells, which increases the circulating pro-inflammatory cytokines. All of this instigate the increase in release or expression of tissue factors. This release of tissue factors starts the mechanism of a mass activation of clotting cascade. Therefore, thrombin generation is greater than antithrombotic pathways. This induces two mechanisms, which is the consumption of platelets, fibrinogen, prothrombin, factor V, and factor VIII. On the other hand, it also instigates widespread deposition of fibrin. Let us go on first for the consumption of platelets, fibrinogen, prothrombin, factor V, and factor VIII. This causes two mechanisms to occur, which is the bleeding diathesis, or the tendency to bleed despite widespread clots, and the hemorrhagic component, the tissue injury. So the bleeding diathesis can be seen in the body as peritche, ecchymosis, weeping wound site, or bleeding mucous membranes. Hemorrhagic component, the tissue injury, can be seen in the body as acute renal failure, hepatic dysfunction, stroke, and pulmonary disease. On the other side of the screen, there is the widespread deposition of fibrin. This causes two mechanisms also, like the tissue ischemia due to fibrin clots in small vessels and fibrin filaments shearing RBCs in the small blood vessels. This shearing of RBCs in the small blood vessels produce signs and symptoms such as microangiopathic hemolytic anemia, schistocytes on blood smear, and a negative result on the Coombs test. The tissue ischemia due to fibrin clots in small vessels produces signs and symptoms such as acute renal failure, hepatic dysfunction, stroke, and pulmonary disease. Same with the hemorrhagic component, the tissue injury. So that is basically a summary of what occurs in the body with DIC. Next, let us proceed on with what are the complications that DIC may cause. First is acute respiratory distress syndrome, or ARDS. There's also bleeding from the GI or elsewhere in the body if you have acute DIC. There is hemorrhage, could also be a heart attack, multiple organ failure, shock, stroke, and venous thromboembolism. Next, what is the medical management for patients with DIC? First is anticoagulants, also known as blood thinners. Actually, it can be taken orally, through injections, and intravenously. The possible side effects that it has could be bleeding, especially if taking other meds like aspirin. So, what are the possible treatment modalities used for patients with DIC? First is clotting factor replacement, oxygen therapy is second, third is plasma transfusion, and fourth is platelet transfusion. What is the possible nursing management for patients with DIC? Again, these are just a few possible nursing management, but there are still more that you can do for patients with DIC. First is to assess and monitor the patient's vital signs. Next is to assess for the underlying cause of DIC. Position the patient in semi or high Fowler's position as indicated. Provide oxygen therapy as indicated. Observe for signs of internal bleeding like pain or level of consciousness changes. Observe for signs of external bleeding from the GI and GU tracts, or the gastrointestinal and the genitourinary tracts. Avoid intramuscular injections and unnecessary venipunctures. And lastly, administer medications as prescribed. Then again, there are still more that you can do for patients with DIC. Next, what are the possible nursing diagnoses for patients with DIC? First is impaired gas exchange related to altered oxygen carrying capacity of the blood, ineffective tissue perfusion related to blood circulation disruption, or it can also be related to microthrombi, deficient knowledge related to insufficient information about the physiologic condition, and the risk for bleeding related to depleted coagulation factors in the blood profile, or basically abnormal blood profile. So, what is the short-term or long-term outlook for patients with DIC? The prognosis depends on the severity of the coagulopathy and on the underlying condition that led to DIC. Assigning numerical figures to DIC-specific morbidity and mortality is difficult. The following are examples of mortality figures for diseases complicated by DIC. First, for idiopathic purpura fulminans, there is 18% mortality rate. For septic abortion with clostridial infection and shock, there is a 50% mortality rate. In the setting of major trauma, the presence of DIC approximately doubles the mortality rate. Basically, these are diseases complicated by DIC and their mortality rate. So basically, in summary, The outlook depends on what caused the DIC. If the initial problem can be corrected, then the DIC will resolve. If not, the physician may prescribe blood thinners to prevent blood clot. People who are taking blood thinners should see their doctors for regular checkups. The physician will want to give you regular blood tests to evaluate how your blood is clotting. That is it for DIC, and this is just a summary of the things that you need to know about this disease. I hope you proceed on to the third video for a summary of information that you need to know about thrombotic disorders. Thank you for watching!